Welcome to the JOMA podcast. I'm your host, Jennie Berkovich, board-certified pediatrician and director of education for JOMA. This is a very special episode of the podcast. It is a Lilly-sponsored educational podcast with special guests Dr. Travis Lewis and Dr. Jose Alberto Palma. Dr. Lewis is executive medical director at Lilly Genetic Medicine. He supports clinical development of various genetic therapy programs from early phase proof of concept through clinical confirmation. As a neurologist, he has a strong interest in neurodegenerative disease with a focus on movement disorders. He completed his PhD training designing viral vector platforms for gene therapy and has continued to passionately pursue novel methods of advanced therapeutics through his career. Dr. Palma is a neurologist and neuroscientist currently serving as executive director of the Neurodegenerative Early Phase Group at Eli Lilly. He completed advanced training in movement and autonomic disorders at NYU, where he later built a distinguished academic career, culminating in his role as professor of neurology. Before transitioning to the pharmaceutical industry, Dr. Palma's research and clinical work focused on deepening our understanding and treatment of Parkinson's disease and related neurodegenerative diseases. If you have anyone in your life with Parkinson's, or you are a healthcare provider that treats patients with Parkinson's or patients who are at risk of developing Parkinson's, this is an episode that you don't want to miss. For more information on Parkinson's, you can visit JOMA, the Parkinson's Foundation, PD Generation, and local genetic counseling services. I hope you enjoy this episode as much as I did. Hi, everyone, and welcome to the podcast, Dr. Lewis and Dr. Palma. I want to thank you both so much for joining me today. Parkinson's is a critical diagnosis to discuss, but I very rarely hear it being talked about through the lens of genetics. So I would love to hear a little bit about each of your backgrounds before we start defining what Parkinson's is and what role genetics plays in it. Dr. Lewis, let's start with you.
Great. Well, really happy to be here. Thanks for inviting us. This is exciting to talk to this audience. My name is Travis Lewis. I'm a neurologist specialized in movement disorders. I'm actually trained in gene therapy as well. So I did my PhD work studying gene therapy with the idea of developing treatments that can slow or change the progression of disease, of various neurodegenerative diseases. And I guess at Lilly now, working for Lilly for about 5 years and running a number of Parkinson's disease studies with the hope of doing just that.
Excellent. Dr. Palma?
Yeah, well, super excited to be here. Thank you for the opportunity. My name is Alberto Palma. I'm a neurologist by training, movement disorders specialist as well. And like Travis, I also did my PhD, and I had some academic life at NYU, New York University, where I was in charge of the atypical Parkinsonian syndrome clinic, which is a subset of Parkinsonism that progresses much faster and much aggressively than Parkinson's, right? And I also had a number of studies around genetics, right? So I'm excited to be here, excited to collaborate with this podcast, and been at Lilly for a couple of years, also involved in neurodegeneration trials and one trial for Parkinson's disease as well, right? So again, very happy to be here today.
Before we dive into the different causes and the role that genetics plays, let's define what we're even talking about. Dr. Palma, very briefly, what is Parkinson's?
So Parkinson's disease is a neurodegenerative disorder characterized by the dysfunction of specific cells in the nervous system, traditionally the dopaminergic cells, right? And this results not only in the traditional motor deficits like tremor, rigidity, troubles with balance and walking, but now fully recognize that there are also non-motor symptoms, right? We have a lot of sleep problems in patients with Parkinson's, mood problems, depression, cognition, autonomic nervous system problems like problems with blood pressure regulation, bladder issues. And it's interesting because we know that a lot of these symptoms can begin before the traditional motor symptoms. A lot of these non-motor symptoms begin sometimes years or decades before the motor symptoms, right? So in a nutshell, neurodegenerative disease where the neurons start to become dysfunctional and eventually they will die. It's a very slowly progressive disease, though. No one, at least most people or no one will die of Parkinson's. They will die with Parkinson's, right?
Thank you. Dr. Lewis, walk us a little bit through the different known causes of Parkinson's.
Yeah, a great question. The short answer is we don't know the most causes of Parkinson's disease. This is something that I think scientists are studying, and we learn more and more all the time. But um, just hammering down a single cause isn't really well known, and I think nobody would stand up on one particular thing. There are a few things that play into it. So there are some exposures that have been shown to increase the risk of Parkinson's disease, things that people experience through life, but these are subtle and increase risk. And then there are some genetic factors that increase the risk of Parkinson's disease or cause Parkinson's disease. There are common genes that can increase the risk of Parkinson's disease, and there are some very rare genes that directly cause Parkinson's disease. And so, but there is genetic underpinning to some aspects of it. But the vast majority, I would say, the genetics make up about 10 to 15% of people with Parkinson's disease. And outside of that, the vast majority of people don't truly know. We call it idiopathic or Parkinson's disease, where it occurs. We know the biggest risk factor is people aging.
You mentioned exposures. What kind of exposures are known to sort of increase the risk or maybe have an association with Parkinson's?
Yeah, there is things like manganese, chemicals that are used in farming that have been associated with increased risk in different populations. These are tough studies to do. It takes large numbers of people and large amount of time related. Other exposures actually may be protective. And again, these are subtle things. It's been shown that coffee slightly decreases your risk of developing Parkinson's disease, as does smoking cigarettes. Now, we don't encourage anyone to start smoking cigarettes. It's not enough of a benefit, and certainly the risk of cancer outweighs that. Certainly interesting. And I think to me, what this information provides to us is a hint of the biology underpinning this neurodegeneration that Alberto talked about. What is causing these cells to become dysfunctional, eventually die? And so I think these have all been great learnings. The challenge right now is that we haven't been able to translate all this new knowledge into drugs or treatments, therapies that slow the rate of progression. And that's, I think, what we're all trying to do.
Thank you. Dr. Palma, how do we go about determining if someone's Parkinson's has an underlying genetic cause? And follow-up question to that, what is the value of doing that investigation? Does it change treatment? Does it change the way that we anticipate that disease is going to progress?
Great question. Look, as Travis mentioned, we know that genetic causes are around 10% of cases with Parkinson's. So it's a small minority, right? So when someone starts developing the traditional motor symptoms and gets a diagnosis of Parkinson's, most likely it won't be genetic, most likely. Right. I will say, though, there might be some factors that may raise the possibility that it's genetic. Number one, obviously, family history, right? If your parents had Parkinson's, if a lot of people in your family had Parkinson's, well, maybe that's a clue that it's giving you that perhaps your Parkinson's might have some genetic risk factors, right? Ethnical background, right? We know that some of these genetic forms are more prevalent in Ashkenazi Jewish people, right? Or in some North African populations. There is also this extremely rare genetic mutation that Travis mentioned that it's going to give you Parkinson's for sure, right? These mutations in a gene called synuclein, alpha-synuclein, extremely rare, no more than, I will say, 10 families, but they are all very localized in areas of Europe, right? So again, I will say that's the main factor, right? Family history, a lot of people in your family. And the other factor sometimes is early onset, a very early onset Parkinson's, right? If you get a Parkinson's diagnosis in your 40s, in your early 50s, that's relatively young. That's way younger than you will expect to develop a diagnosis of Parkinson's, which is usually in the late 60s or early 70s, right? So if that's the case, it's possible that there might be some additional genetic component, right? To answer your second question, is there any value? And maybe we can talk more about that later. But the established treatment for Parkinson's is going to be the same, regardless of whether it's genetic or non-genetic, right? And right now we have a number of approved medications that are to treat symptoms, right? They're going to address your symptoms. They won't do much to slow the progression of the disease. That's why we have a number of clinical trials, but we'll talk about that in a second, right? So again, the symptomatic treatment, that your traditional treatment with carbidopa, levodopa, with dopaminergic agonists, with a number of medications that have been approved for a long time, it's going to be very similar in genetic and non-genetic forms. So it doesn't really matter if you have a genetic testing done, right? The treatment is going to be the same. I think the genetic testing could be useful for two reasons, right? If there is a high suspicion that you may be, that your case may be familiar. Number one is to provide potential eligibility for clinical trials, right? If you are very interested in potentially participating in clinical research, having that piece of information early on could help you figure out which opportunities you might be eligible for or your beloved one, right? So let's say if you have a family history of Parkinson's and you undergo genetic testing and you get that positive genetic result, again, that may not change your symptomatic treatment, but may give you options for clinical research participation, right? The other reason is if maybe you are interested, you want to understand more about your family, you want to be more knowledgeable about what's going on in your family, or because you have these aggressive forms of rare genetic Parkinson's that we were talking before, extremely rare, right? So in that case, I think could be useful for counseling purposes, right? If you want to plan in advance what's going on, or you want to be mindful of your disease and what's going to happen in the future, maybe having that genetic piece of information, it could be helpful. I always say this, it's always good to have some genetic counseling before doing genetic testing, right? To fully understand what you are going through, to fully understand what happens if some of these variants are positive, and what are the potential implications, right? So always highly recommended to before doing your genetic testing, do some genetic counseling to fully understand what you're up for. Right?
When I think about other chronic diseases that we know have a genetic component or more prevalent in certain populations like Ashkenazim, we often recommend screening for these things up front. We do sometimes like premarital screening, very common in our communities. Is the same true for Parkinson's?
The answer is no. The short answer is no. And there is a reason for that, right? The panels that you're mentioning, they're usually including very tough and very, very nasty diseases, right? Like, let's say, Tay-Sachs or familial dysautonomia, or some forms of very aggressive diseases that are going to really impact the quality of life or the survival of the patients, usually in the pediatric time, right? So these are usually diseases that are going to start very early on, right after the baby's born or even before, right? So it's natural that before getting married in the Ashkenazim and communities and other communities, they want to have that piece of information, right? Okay, how is that going to affect my offspring? If I'm carrying a mutation and my future spouse is carrying the same mutation, how's that going to affect our children, right? In Parkinson's, that's not the case, right?
What I like to tell patients is, this is education. You should know that it's out there. You should know that there's potential for genetic risk factors and you should understand what that means, right? That it's a very low likelihood that even if you carry the mutation, there's this question about penetrance, that it's not 100% certain you'd get the disease. And that's where the genetic counseling comes in. But I think it is important for neurologists and providers, patient care providers of all types, to be aware that these genetic underpinnings exist and provide that information to patients so that they're aware, right? Some patients don't want to know, don't care to know. Maybe it's too much, or certainly at the time of diagnosis. These things are all very important considerations. But some people really, become empowered when they get these diagnoses or want to learn more about the science or their particular condition. And so I think not telling those types of patients that genetics can be important, that's something you can do and learn about yourself, can be a disservice to some of those people. So I think I like patients to know that genetics can be an important part. They can make the decision whether they think testing is important for them. And that big piece then is And if you don't know, there's no opportunity to enroll in clinical trials that are involved in potentially treating patients who carry these genetic mutations. And I think that's important as we're kind of getting there, is that as we've learned more and more about Parkinson's disease, the biology behind it, and some of the genetics underpinning that, there are a number of clinical trials out there for various forms of various genetic forms of Parkinson's disease. And if you don't know your genetics, you simply would not be eligible or even be aware of those trials. So I think that's kind of an additional piece where patients can make that ultimate decision for themselves. Is this something that I want to know?
That makes a lot of sense. I feel like we're really itching to get into like the treatment section of like available treatments. But before we do that, I'm thinking sort of like through the perspective of a PCP. If somebody comes and is displaying maybe early signs of Parkinson's, whether it's early onset or more later in the expected age, more common age, what is the typical workup like, and how is the diagnosis ultimately made?
Sure, I can start. No, it's a great question. So, I think that Parkinson's, to start off by saying that Parkinson's is extremely common. And so, uh, most people will know somebody, or maybe even have family members, one or two family members. And that's just because it's a very common disease that increases the prevalence the older you get. Because of that, many of these people are not going to be seen by a neurologist or even a subspecialty within neurology, a movement disorder neurologist right away. Many are going to be at their primary care physician getting a blood pressure check. And maybe the primary care physician is, they're very busy, short visits, and they see something subtle, right? Like maybe a little slowness in their movement, a little instability, a little tremor in a finger or a hand, and start, think, well, could this be Parkinson's disease? There are some things that they can do at that stage. I'd say, especially in places where finding a neurologist is difficult, more rural places, or even urban places where the time to get in to see a neurologist can be a very long time. There are things I think even a primary care doctor could. So we often will try a low dose of the carbidopa-levodopa medication. If it works and improves that tremor or some of those symptoms, that's a pretty good signal that this is Parkinson's disease that we're dealing with. Again, there are all these kind of subtle, more rare, but rapidly progressive versions of Parkinsonism. Even if you feel, as a primary care doctor, not a neurologist, feel confident that this is Parkinson's disease, if you see some of these unusual signs or symptoms or unusual rate of progression, or if you're just not sure, I would always recommend to get them in to see a neurologist. A general neurologist is certainly capable of managing this as well and helping to then connect to a movement disorders neurologist. Again, there are these very, very rare versions of rapidly progressive non-Parkinson's disease, Parkinsonism. And I think for those, specialized care is really important to get to. So I think from a primary care specialist, knowing that Parkinson's is very common, they're likely to see it, that there are things they can do to diagnose or to feel comfortable with the diagnosis, but at least in the interim, as the patient's waiting to see a neurologist for a more definitive diagnosis, and that there are these genetic underpinning aspects and also these rare forms of more aggressive Parkinsonisms, in which case, the management is much more kind of involved and sophisticated, and seeing movement disorder specialist would be very much worthwhile.
Makes sense. I want to switch gears a little bit and start talking about treatment, because I'm guessing there's a whole lot to say about it. Dr. Palma, you mentioned that ultimately having a genetic cause isn't necessarily going to change treatment. Can you clarify a little bit about what treatment even looks like for Parkinson's, regardless of the cause, and where that maybe is going to deviate if we know that there's a genetic component?
Sure. So as mentioned before, right now, we have no approved therapies that can slow or stop the progression of the neurodegeneration, right? So all the treatments that are available are aimed at improving symptoms or slowing the progression of, not the progression, the severity of the symptoms, right? So one medication that Travis and I briefly mentioned before is carbidopa-levodopa, right? This is the most commonly used symptomatic treatment for patients with Parkinson's. It's been around for decades, and it works very, very well in early Parkinson's, regardless of whether they have genetic forms or not, right? So usually for patients with initial symptoms, in mild tremors, mild rigidity, mild balance issues, that's the only treatment they need, right? Carbidopa, levodopa, it works very well, and their tremor will sometimes even go away completely or ameliorate significantly, as well as the balance and the rigidity, right? So this is what we call early Parkinson's, right? These are patients that in the initial years, they respond well to levodopa. That's all they need. Then you have a little bit more moderate stages, right? In which the symptoms are getting less mild or less benign, and the response to levodopa is either not as good as before, or they are developing complications related to levodopa, right? Because levodopa has a number of complications, right? Which are essentially, just to simplify things, is extra movements, right? So in Parkinson's, you have the reduction of movement, right? Patients become very rigid. And when you take that treatment, it can cause the opposite problem, which is extra movement, right? These are called dyskinesia. That's a technical term, right? So many times in patients with moderate Parkinson's disease, they have levodopa-induced dyskinesia, LID, right? And so the way we neurologists treat this and movement disorders treat this is they reduce the dose of levodopa, but they need to add something else, right? And this is what we start adding adjunctive to levodopa treatments, right? There are a lot of those approved, right? And they work relatively well. They are not perfect, but they work. I'm talking about dopaminergic agonists, some forms of catechol O methyltransferase inhibitors, MAO-B inhibitors, right? So that's when we start adding treatments to levodopa, when patients start taking more than something else apart from levodopa. And then we have more advanced therapies. And again, I don't want to bore the audience too much, but this is when we start talking about deep brain stimulation, right? This is a therapy that has been around for decades as well, right? In which patients undergo a relatively minor, I wouldn't call it minor because it's still neurosurgery, but it's not too aggressive, but basically they undergo an implant of electrodes in their specific brain areas that control movement that are affected by Parkinson's, right? And what the deep brain stimulation does is it reduces the need for levodopa, right? So the patients get the benefit, the motor benefit of levodopa without the side effects. And then there are also some additional therapies for more advanced patients, like intraduodenal levodopa, right? So patients need to get like a minor surgery to get a little tube into their digestive system so that they can get an infusion of a levodopa form that it's absorbed in the small intestine. And now there are also subcutaneous forms, right? But again, none of this is going to change whether the patient has a genetic variant or not. The response is very similar. It is true that some genetic variants have a slightly more aggressive progression, right? I'm talking about GBA variants. And then you have other variants that have a slightly more benign progression, like LRRK2 variants, right? But bottom line, nothing in terms of their genetic background will change how we treat patients from a symptomatic point of view. Obviously, I focus on the motor symptoms. If a patient develops non-motor symptoms, you can always treat that with available symptomatic therapies. I'm talking about some cognitive dysfunction. There are available treatments to ameliorate the symptoms. And the same for blood pressure problems or sleep problems or mood problems, right? Again, nothing is going to change the symptomatic treatment. What the genetic mutation will change is your potential eligibility for clinical trials aimed at treating patients with that specific mutation, right?
That makes a lot of sense. Before we go into the clinical trials, Dr. Lewis, obviously a lot of available treatment options sort of sounds like progressive. And as the disease progresses, we add on more and more. Anything, not to get controversial, but like anything in the sort of like alternative sphere that's been tried or is evidence-based, or I'm sure patients often come and say, okay, but like what else can I be doing? Lifestyle changes, like, right? Anything else, minimizing exposures, that type of stuff.
Yeah, no, really great question, really important, and certainly a key thing. And I think there are a number of things that have been shown quite rigorously actually in clinical trials, things like exercise that has been well shown to improve people's ability to live with Parkinson's disease. That means potentially slowing the rate of progression, and improving their balance, their strength, those kinds of things. So things like cycling, things like boxing, actually Tai Chi have been used a lot. There are other challenges that people might experience. So, not just small, we think of Parkinson's as a disorder of smallness, I guess, is smallness of movement, the slowness and smallness of movement. There's also smallness in voice. So you can have hypophonia, have difficulty speaking. And so there are kind of occupational therapy type programs which, train you to speak more clearly, and because you have to kind of retrain your brain a little bit. So there are certainly a lot of non-therapeutic interventions that have been that are used and should be encouraged. There are also a lot of alternative things that have been evaluated and that I think a lot of patients are interested in. And I would say that the vast majority of them have either not been studied or when they've been studied have been proven not to work. Alberto, I'm not sure if maybe I'm missing any, but things like anti-inflammatories, things like urate,
coenzymes,
coenzyme Q. So all these things that have kind of been out in the literature and people want to use, if they've been proven not to work, I think we try to tell our patients that you're spending money that isn't probably going to help. It's tricky, right? I think if a patient feels empowered by wanting to do things that they think they believe in, I believe in that. I think the placebo effect is real and strong, and that's worthwhile. So I don't, if it's safe, I don't necessarily discourage, but I want people to know that this has been studied. Many of these have been studied and shown not to be effective at actually slowing the disease.
That's interesting. One of the very common lines we say very frequently on the podcast is movement is medicine. So it's interesting to see that reinforced even in a chronic progressive disease like this. Any dietary changes that have been found to be helpful? I see a lot of interest in things like the anti-inflammatory diet for other neurodegenerative diseases. I don't know how evidence-based that is. I'm curious if there's a role for any dietary changes in Parkinson's.
Well, two things. Number one, obviously, gastrointestinal problems are very common in Parkinson's, right? So constipation is almost universal, right? So specific changes in diet, like adding fiber, reducing high glycemic index carbohydrates, adding right vegetables, all that to improve constipation per se is going to make a difference in the quality of life of patients, right? A lot of studies around the microbiome, right, in Parkinson's, right? We know that microbiome is altered in Parkinson's, right? What we don't know yet is what's the implication of that. If that's a consequence of Parkinson's, if that's partially a cause, or is just also related to the medications, we don't really know that yet, right? But in general, as a physician, what we recommend is a balanced diet, vegetables, fruit, low carbohydrates, healthy life, right? And all those. Look, the only diet that there is evidence that does anything for your health overall, regardless of Parkinson's, right? It's the Mediterranean diet. That's the only diet that we have solid evidence for that. What's the Mediterranean diet? Well, nuts, fish. Try to minimize your consumption of red meats, fruits, vegetables, olive oil, and a little bit of yogurt here and there. That's always going to be overall good for your overall health, right? To reduce risk factors that are also associated with Parkinson's, right? I'm talking about diabetes. I'm talking about cardiovascular problems, high cholesterol, right? All those factors are also increasing the risk of Parkinson's in the long term. So anything that we can do to minimize that, it's always going to be helpful. Now, specific diets like the anti-inflammatory, or some people ask me sometimes about intermittent fasting, right? Or I don't think we have full evidence to specifically recommend that against Parkinson's, right? Again, anything that keeps you healthy, that keeps you balanced, that can reduce your dietary cardiometabolic risk factors, I will say it's a good idea. Movement is a great idea. Anything that makes sense, that is not too extreme, I will probably say go for it. Right?
That makes a lot of sense. I was interested to learn that other chronic diseases increase your risk of Parkinson's, I think when we think of like prevention of high blood pressure, we tend to think of that sort of trifecta, and we think of it as in a vacuum. But I'm understanding there's evolving evidence that those by themselves are independent risk factors for developing conditions like Parkinson's.
Indeed. So any changes in diet that can minimize these risk factors will potentially also have a potential beneficial impact, either in preventing Parkinson's or in making the quality of life of affected patients a little better.
Excellent. I want to spend our last little bit of time talking about some of the research that you guys are doing, specifically the clinical trials for treatments as it relates to genetic forms of Parkinson's. Dr. Lewis, can you start us off?
Yeah, I mean, just to start by saying, this is what I think all scientists and all drug developers and all pharmaceutical companies would love to be able to do. I mean, we're all, Alberto and I are both medics. We've seen these patients, and we want to find a way to not just find more ways of treatment, right? There's 18, I don't know how many, probably 18 or 20 versions of carbidopa, levodopa out there, but they all are going to do the same thing in general, and not change the rate of progression. So this is the holy grail. We understand this. We understand more and more about the science, the biology behind this, and we're trying to intervene on that. But these are hard. As Alberto mentioned, these diseases are diagnosed often by the motor symptoms in your 60s and 70s, but there have been non-motor symptoms probably going on for many, many years before that. We know that. And often those are dysfunctional, or there are some dead neurons at that point. And so we don't think we're in a position where we can regrow neurons, but how can we stop this degeneration? And doing so late is very difficult because the process has been going on for 20 or 30 or 40 years. It's a hard challenge, and I think something that companies have been working at for a long time and failing at for a long time, to be frank, but not for lack of effort. I'd say some of the recent data that's come out of the dementia space, the Alzheimer's space, is extremely encouraging. I mean, it's unbelievable that we have now 2 approved medications that can slow the rate of progression of Alzheimer's disease. That proves that it's possible to move the needle a little bit, in my mind. We need that in Parkinson's disease as well, and we're looking for that. So I'd say there are a number of clinical trials ongoing looking to intervene in Parkinson's disease and slowing the rate of progression. Lilly, where we work, is involved in a number of those. Other companies are doing it as well. Some are enrolling patients or looking to enroll patients or intervene in patients who have non-genetic forms of Parkinson's disease, or all comers, meaning anyone with Parkinson's disease, irrespective of if you carry a mutation or not. And others are very much specific to people with these mutations, as I mentioned. So there are clinical trials out there for people who carry the LRRK2 mutation that Alberto mentioned. Slightly slower, more benign course, although for any individual patient, there's a spectrum there, and it's, I think, nice to know, but still they're going to progress. And then there are a number of so there's some LRRK2 inhibitor oral molecules that are being studied that are interesting. And again, I think this is where if you have that mutation, it might be nice to know. Same for GBA-PD. So I've been closely involved in Parkinson's disease with GBA mutations. This is the mutation that's, if you carry 2 copies, you can develop a Gaucher disease. And there are various different types of Gaucher disease. But I think this community is well aware of that. There are very, very aggressive forms of Gaucher disease that affect children, very, very young children, maybe at the time of birth, or a little bit later in their childhood. And then the more common type 1 Gaucher disease, which seems to be much more peripheral, although certainly they're at increased risk of Parkinson's disease. So that's for people who have 2 mutations. If you carry 1 mutation, it increases your risk of Parkinson's disease. So you're not going to develop Gaucher disease, but you're at an increased risk of Parkinson's disease. That's hard to really get across, right? Because not everyone gets Parkinson's disease. So you have the population has a certain risk of developing Parkinson's disease. If you carry this mutation, that risk is much higher, but it goes from about 1.5% to 3% risk, relative risk, something like that. So So it's still subtle, but it's important to know. And so there are another number of clinical trials evaluating treatments that are aiming to slow the disease progression, Parkinson's disease with GBA mutations. I guess I'll pause there. I can talk a little bit more about our trials as well if you're interested.
I think that sounds good. I want to give Dr. Palma a chance to maybe respond or elaborate on any of those trials.
Again, I fully concur with Travis, right? So you have a number of trials going on for Parkinson's, idiopathic Parkinson's, right? And that means that you don't need to have a mutation. And again, this is by our company and by other companies. And these are typically targeting the protein that appears to be involved in the pathogenesis of Parkinson's, and one of the key proteins, which is called alpha-synuclein, right? So a lot of these treatments, a lot of these therapies are targeted towards that specific protein in an attempt to maybe block it with an antibody or with other type of mechanism. And then you have these other genetic targeted therapies for GBA mutations, LRRK2 mutations that Travis summarized. And because these are the two most common variants found in genetic Parkinson's, right? That's why a lot of companies, including Lilly, are interested in these two specific targets to potentially help these patients. And an ongoing question is, by targeting these genetic targets, these LRRK2 and GBA, can we help only the patients with the genetic mutations, or maybe they can also be useful for the patients without the genetic mutations, right? That's an ongoing research question that we have and a lot of people have. And hopefully by proving that we can help the subset of patients with genetic mutations, potentially we can learn if we can help the larger subset without mutations.
Thanks. I completely agree. And I'll just add, I mean, we're so happy to be on this interview on this podcast because I think educating around Parkinson's disease in the community, educating around the genetics of Parkinson's disease, and then educating about clinical trials and some of these advanced therapies that we think are going to be required to make this major shift, right? To actually change the rate of progression of the disease. These are really tricky, and so I'll dive a little bit deeper into what we've been doing, just because I think from an education standpoint, it's really interesting. I think it's interesting, right? We've talked about gene therapies or genetic therapies. So we've kind of danced around this a little bit, but not only is Parkinson's disease a complicated, challenging disease, and not only is the genetics of Parkinson's disease complicated and challenging, but some of these technologies that we're using to try to change the progression are complicated and challenging. So genetic therapies is a big umbrella. It entails a lot of different types of technologies that we have. The one that I've been working in for a long time, and I mentioned I did my PhD work on it, is viral gene therapy or viral vector gene therapy. The idea here is that use a virus, non-functional virus, as like a Trojan horse, this tool to target neurons and deliver a therapy or a gene. And so this is where the genetic forms of Parkinson's disease are really interesting, because we know that people with GBA mutations who have Parkinson's disease, we know that those mutations in GBA affect the function of the neurons. And we believe from animal studies that by replacing that GBA, by repairing that function, we can stop the progression in animals. That doesn't mean it'll work in humans, and that's where these clinical trials come in. So we have a clinical trial where we're using an AAV vector, so a viral vector, to deliver a healthy functional copy of the GBA1 gene to neurons in people who carry this mutation and have Parkinson's disease, to see if we can change the rate of progression in those people. That's a lot, right? Trying to explain that to a patient is tricky, and we want them to really understand what they're getting into. So I think that's where the education piece really comes in. What is a viral vector? How is it delivered? How does it do its thing? And then what's the likelihood that it's actually going to change the disease progression? These are things we're trying to understand. Other forms of genetic therapies are things like RNA therapeutics. So we can use RNA therapeutics to suppress the production of things like alpha-synuclein. As Alberto mentioned, it's one of the most important drivers, we think, of the dysfunction of neurons, the abnormal formation of alpha-synuclein aggregates. Slower disease. We have clinical trials now using both of those technologies at Lilly, and others are doing similar types of work, which I think is really exciting, interesting. We hope we can move the needle, but we don't know.
Dr. Palma, you said something in the beginning that nobody dies from Parkinson's. People die with Parkinson's. If someone is listening, either themselves or have a diagnosis or someone they know, it sounds like a lot of overwhelming treatment options. Certainly the ones we talked about that are more conventional, not benign by any means, have, their own side effect profile. And they're thinking to themselves, okay, if this is not curable, what is the benefit of trying to treat and sort of target each and every symptom? What if I just let it progress? It's not something that's ultimately going to be the cause of death. So what's the benefit other than just keeping someone comfortable?
Yeah, great question. Well, it's not only keeping someone comfortable, is restoring your quality of life or improving your quality of life, right? So as I mentioned before, in the early stages, that can be accomplished, right? With the current treatments, right? We know that the disease is going to keep progressing in the background, right? The neurons are going to remain dysfunctional and they are going to keep dying, but at least we have these symptomatic treatments that can give back patients a lot of their quality of life. And I remember a patient who told me, the tremor is mild, my rigidity is not that bad, but I cannot play golf at the level that I used to play, right, doctor? And I said, I understand. We're going to start this treatment, this levodopa carbidopa. And in a week, he was back into the golf course playing as he was playing before. It is true that that's not going to last forever, right? This is slowly progressive. Maybe he's going to keep that level for 2, 3, 4, 5 years. And then this is when the stage of adding more medications begins, right? But the goal is the same, is to try and maintain their quality of life or try to adjust that, right? At the end of the day, as a physician, you want to have a conversation with your patient, right? And understand what works, what doesn't work, what are their expectations, their goals, right? If someone is going to be most of their time sitting, reading, watching TV, meaning they don't need to be too active, maybe the potential side effects of the medications or the potential complications that I was mentioning before, these dyskinesias, they might not be worth it, in which case they are okay. They are okay with a more limited mobility range, in which case they might not need as many medications, right? But then you have other type of patients that want to remain very active. They want to remain functional. And, it is surprising, and maybe Travis also has this experience, how most patients with Parkinson's, in my experience, they are willing to go the extra mile to try treatments, even though they understand that a lot of these treatments might not modify the progression of their disease. But, they are willing to undergo this neurosurgery I was talking before to improve their symptoms, even though this surgery will not do anything to stop the progression of the disease. And still, a lot of patients choose to have that surgery done, this neurosurgery, right? So it's just a snippet to show you that a lot of these patients are very, very motivated to keep their quality of life and to try and do as much as they can with medications, with surgery, and with non-pharmacologic measures, right? To try and remain as functional as they are. And that's why a lot of these patients are also interested in clinical trials, right? They understand that they are slowly deteriorating over the years, and they want something else that can slow or stop, ideally stop, and in the future reverse the damage that they have, right? That's what we will love, right? To develop something to potentially reverse all the damage that has been done, right? So that's why a lot of patients choose to have these symptomatic therapies and to eventually participate in trials, right?
I appreciate that. I want to end on a message of hope and empowerment. What is maybe one or two like key takeaways, or I usually call them pearls on here, like pearls that you want either families that know they're maybe at risk, or maybe even PCPs who are listening who maybe have this on the forefront of their mind. What do you want them to know about Parkinson's? Dr. Lewis, let's start with you.
Sure. Well, great way to end. I guess I would say that that this is a common disease. Many people will experience this. It's also a very treatable disease. There are a lot of great treatments, and you can have a great life, and you can maintain a quality of life for many, many years. So it's not, it's challenging. Nobody wants the diagnosis, but it's not a death sentence, I guess. And I think this is also a really exciting time. And I know people say this, scientists say this forever. We're learning more and more about the biology. We have more and more technologies to try to intervene on that biology to really make a difference. And I think it's just a really exciting time in neurodegeneration and neuroscience that hopefully in our lifetime we'll see treatments that can change, that aren't just symptomatic, that can change the disease. And so I think education, empowering patients to learn about the disease, to understand whether learning their genetics might be important to them, and then what the treatment options are available and what the future looks like. Because I think it's a bright time.
Excellent. Thank you. Dr. Palma?
I think Travis summarized it perfectly, right? I think this is a disease that it's treatable, although we can only treat symptoms right now. However, we are, I will say, at the dawn of a new genetic medicines era, right? Where we can specifically target with very precise tools specific pathways of the disease that we know are involved with Parkinson's disease. And hopefully that will result in a meaningful, beneficial change for our patients, potentially slowing their disease progression. And as Travis mentioned, I hope that we can see that potentially in the next decade, 2 decades, certainly within our lifetime.
Excellent. I want to thank both of you so much for your time today and sharing your expertise.
Thanks for
Thank you for the invitation.